Let me tell you a couple things in general about cardiac literature, and actually Rick just alluded to it at the end of his last talk, which is that cardiac literature combines a whole lot of endpoints, and depending what they look at, it may make a difference in what you care about. Some of it looks at only revascularization, some of it looks at only death rates, some of it looks at only heart attack rates, some use combinations of those three. And it makes it a little bit difficult for us to know how to interpret individual studies. The other thing about cardiac literature that is frustrating, to me anyway, is if you look at a lot of the literature in depth, they use the timing on what they use in a cardiac paper isn't the timing that we tend to use in practice. What do you use as your timing to decide where to sort of drop the flag on cardiac chest pain? I use the end of pain, not the beginning of pain. I use the beginning of pain if I'm worried about thrombolytics or getting somebody up to the door to balloon time. But as far as this low-risk person who's had pain for 4 hours at home, but it's been gone for 6, I use that end of pain as my timing. And we'll come back to that as to why that might be important. But that's not used in literature. That isn't used very much at all in literature. And I think that is a lot of what we do in our practice as far as how to use particularly markers. And we'll get into that some more as well. The other thing that's frustrating about this particular topic is, what are we chasing here? How good are we at picking up heart attacks as emergency people? How good are we? We're damn good. 96%, 98%. We pick up ACS patients acutely. That's really good. Problem is we're chasing that 2 to 4% we miss. And I have to tell you, I mean, when I was a medical student, like as we all were when we were in school, you know what a heart attack's like. It's crushing pain. It goes to the shoulder. They're short of breath. They get diaphoretic. You know exactly who has ACS. I'll tell you now, 20 years into my practice, I am completely confused. I am totally and utterly confused. That 2 to 4% that we are chasing our tails about, I'm not sure we'll ever find, to be perfectly honest with you, unless we go into our waiting room and we get EKGs and markers serially and then stress everybody who's sitting in that waiting room on their way out the door. I'm not sure we'll pick them up. I'm not sure we'll ever pick them up. And part of the frustration with what we're going to talk about this next 2.5 hours is I'm not sure I'm going to give you any tools to make you a whole lot better. We'll talk about that. You can decide. What I'd love somebody to do is do, you know how we have all these risk stratification schemes for PE? Where if this plus this plus this plus this plus this is a high likelihood, none of this is a low likelihood. We don't have really good risk stratification schemes out there. I'll tell you about some of them in the second half of this two-talk thing, but we still don't have any that are good enough to pick up that 1 to 2% that we tend to miss. So that's part of the pitfalls. That being said, let's get into this deal. Abstracts 1 through 5 look at a systematic approach versus a non-systematic approach to looking at people who have heart attacks, who have a potential ACS. How many of you have a protocol? We have an ACS. We have a whole risk stratification protocol in our emergency department. If you don't, it's worth thinking about. What we do in ours is we actually have checkboxes. Somebody comes in and we have ACS on our radar screen. We pull out page 1, which is just a set protocol that gets serial markers at a certain amount of certain time points, serial EKGs at certain time points, certain labs are sent at the very beginning. We have certain things that they get aspirin, they get beta blockade if it's indicated, blah, blah, blah. So we do all the things we're supposed to while we're looking at them for ACS. Is that any better than you going to the bedside and saying, I think this one might be, and I'm going to get tests the way I think I should, and with a non-standardized approach? Abstract 5 is the one that looks at the physicians versus, the I do it my way versus, we'll look at the rest. It looks like with the standardized protocol. But abstract number 5 is by Jim Christensen, who's up in Canada. And what he did is basically just watched a bunch of emergency physicians take care of people who have heart attacks. And each one did it kind of on their own system, how they kind of felt like they wanted to do it. And he found in this paper they missed 5.3% of MIs. They sent home 1 in 20 MIs. By doing this as the I do it my way thing. If you look at some of the other papers in this section, the miss rate when you have a systematic approach drops to about 3%, 2 to 3%. So it looks like at least a systematic approach is better. And actually there's a couple things in these systematic approaches that I think are helpful. Circle abstract number 3. Abstract number 3 is what's called the Erlanger accelerated protocol. You guys ever heard of this? Any of you doing this, the 2-hour protocol? The 2-hour protocol is fabulous. What this does is you see patient time 0, okay, you drop the flag, and you think it's ACS. You send markers time 0. And the markers that most of us tend to send are CK-MB mass and a troponin. You can also send myoglobin, but that actually turns out to, although more sensitive, most of us don't do it, so we'll throw that away for the moment. Just send troponin and CKMB mass. I get a 12 lead at that point, put them on continuous 12 lead monitoring. Then 2 hours later, do the same thing. Get a 12 lead, send those 2 markers. What this does is you're going to look at an incremental increase in those markers. And it may not hit the cutoff level of being concerned, but it is an incremental increase where if in that 2-hour time period the CKMB goes up by 1.5 or the troponin goes up by 0.2, you admit that person. The sensitivity for picking up ACS is about 93 to 94%. It's also 93 to 94% specific. Nice. Now what does that do? That helps us jumpstart admission on the person that turns out to have ACS. Still doesn't help us with that percent that falls through the cracks. So I like the Erlanger protocol for helping us jumpstart the person that needs to get admitted and worked up upstairs, but it still doesn't help me pick up those ones that fall through the cracks. These, all of these accelerated protocols also then have a 6-hour, sometimes 8, often 12, goes out that far. Most of us don't have the kind of emergency department where you can watch somebody for 12 hours while you're getting markers. You either admit those folks if you're concerned, or you put them in your CPU if you have one. But the bottom line on these protocols is a standardized protocol is a little bit better than just doing it randomly the way you want to. And if you want to do a standardized protocol, drop in the Erlanger part of it, because you'll pick up the ones that have ACS earlier and can at least get them out of your ER and not do that whole futzing around trying to find that, you know, those few people that are missing through the cracks. At least some of them you'll get in early. Has that been your experience, those of you that use it? We've just started this. We pushed this through with our cardiology department recently to add this to our new ACS approach to try to get people that are positive upstairs more quickly. And again, positive doesn't mean they hit the cutoff that says, yes, indeed, you are ruling in. It just says the leak is there, and we're going to keep you in the hospital. Okay? That's the scoop on that. So standardized probably better than just random. How about responses? Oh, go, please.
If it's negative, you send them all?
No, if not. If it's negative, then you finish out the protocol. So you have a 2-hour, you do the 2-hour deal. So what it does is front load getting them up if they're positive. It doesn't help you in that, okay, it's not positive yet, let's check one at 6, and then decide what to do at that point. If they're both negative, then you have to decide what to do. By the way, markers, we'll come back to this at the end of this half hour. All markers mean is damage. They don't mean no ACS. Okay, you have to know what your marker gives you. What your marker gives you is they've leaked. Something's been damaged. It doesn't mean they don't have acute coronary syndrome. You've all seen the person with stuttering pressure like chest pain. It's there for 10 or 15 minutes. It goes away. It's been there 6 times today. They don't leak one bit of marker, and they go upstairs and they have bad vascular disease when they get looked at with cath. You know that. You know you've seen those cases, and they don't necessarily leak. It just means there's been damage done. So markers have some pitfalls. We'll come back to that. Now, how about response to treatment? You all know it is really bad form to have somebody leave the emergency department having just chugged the GI cocktail, drop outside and having their VFib arrest and come back with a Mylanta mustache, right? They got better with a GI cocktail, therefore it must not be cardiac disease. You all know, I think that's pretty well known across the board these days, that if somebody's pain goes away with a GI cocktail, that doesn't make it non-cardiac. That doesn't mean it's some sort of gastric something. You can absolutely, there's one abstract in here, but there's a bunch out in the literature that basically say, don't use that as a way to say, oh, it's got to be GI and not cardiac. Now, but what about nitro? Because nitro is specific, right? Nitro is what we give to make the chest pain go away. 2 things about nitro, and again, please don't shoot me. A response to nitroglycerin doesn't mean it's cardiac, and no response to nitroglycerin doesn't mean it's not cardiac. That's what the next 3 abstracts look at. Abstract number 7, what they did is took 233 patients coming in with chest pain who were getting evaluated. They gave them nitroglycerin. What they looked at was their ultimate diagnosis, was it cardiac or not, and what they did as far as response to nitroglycerin. In the patients that had so the people that had final diagnosis of cardiac chest pain, okay, the ones we would expect to respond to nitroglycerin, was 1/3 of the patients of those 233. 70% of those patients had complete response of their chest pain to nitroglycerin. Of course they did. They had cardiac chest pain. Non-cardiac chest pain, 73% had a complete response of their chest pain. It was basically equivalent. Equivalent. Whether you had cardiac or non-cardiac pain, you had an equivalent response. Abstract number 8 basically says the same thing. Okay, you have a great response to chest pain, cardiac or not, response to nitro. And we have this curmudgeonly, kind of bombastic Bostonian cardiologist at Harbor. He's great. You know he's in the ER because he has this, I can't do a Boston accent. I really wish I could, but he has this booming Boston accent. And he'll go to the bedside of a patient we're admitting for ACS, and he'll say, if it doesn't respond to nitroglycerin, it can't be cardiac. Or, you gave nitroglycerin, it didn't respond, it's not cardiac. You hear it across the room, cardiac, it's not cardiac. Well, is that true? Is he right? If it doesn't respond to nitro, does it mean it's not cardiac? Let me give you this scenario. I have crushing substernal chest pain. It radiates to my left shoulder. I'm feeling a little sweaty. You give me nitro. It doesn't get better. Do you think it's not cardiac now? I don't think so. That's the one I'm on the phone saying, it's not responding. He needs to go to the cath lab. This one's really sick. They actually found quite a few patients with honest to goodness, flat out cardiac chest pain, true MI stuff, had no response. In this particular paper, it was 15 of 35 acute MIs had no response to nitroglycerin. So responding to nitro doesn't mean it's cardiac necessarily. Not responding to nitro doesn't mean it's not cardiac necessarily. So response to meds, if you want to just take a cut to the chase deal, don't let response to meds change your mind. If you go to the bedside and you think it's cardiac, it's cardiac. Whether they respond to meds or not, it's cardiac. You've made your mind up ahead of time based on their clinical scenario when they present. Don't let the meds change your mind. One way or the other, don't let it change your mind. How about risk factors? We all do this. It's part of how we risk stratify, and we'll talk about risk stratification schemes in the second half of these two talks. How good are risk factors? And we all know it's the smoking, diabetic, the person who, of a certain age, blah, 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 family history, etc., hypertensive. Do they help you with people who have potential ACS? Abstract number 11 is actually an interesting paper. I think every program in the country did this paper as part of Journal Club that looked at ACS. In this particular group, this is an ACS registry of 10,000 patients, almost 11,000 actually. And they looked at ACS that was diagnosed in 8% and looked at how many of those people had risk factors. And it turns out that a lot of the older people, by older in this paper I am offended, they call them over 40, were the older people. Over 40 risk factors didn't help you. Where they helped you was the under 40 population. Because over 40, you're already concerned, right? You already kind of raise your eyebrows, somebody over 40 who comes in with chest pain. But people under 40, it really did help. If you have somebody 32 who's been diabetic for 10 years, who has hypertension, and they're having chest pain, you worry about those. Risk factors helped you diagnose ACS in younger people. It didn't help so much in older people. So risk factors actually are helpful in the younger person. And I'll tell you, the youngest MI I've seen is 23, flat out, massive anterior MI. I've been a diabetic since childhood. And I'll just tell you one more fact that's a little scary. Right now, 1 in 4 children born today in the United States will be diabetic by the age of 20. Because 1 in 4 children in the United States is obese, and obesity will be a huge contributor to coronary artery disease. I guarantee we're going to be seeing early coronary artery disease. Flat out guarantee it. We have a huge obesity pediatric population at Harbor. Remarkable obese population at Harbor. These kids are all coming in diabetic at 8, 10. I mean, it's huge. The impact on coronary artery disease is going to be huge. So these risk factors are going to be particularly important as especially those of you who are young in this room, have your practice go on for the next 10 or 20 years without question. Now, how about chief complaints? We know that chest pain is what we worry about. Abstract, which one is it? There's one of these in here. Abstract number 12 did a retrospective review of 721 patients, all true MI. So they all had MIs. And they went back and looked at the chief complaints of those 721 people. Well, 53% had typical chest pain. Thank you very much. 7% had the decency to actually present a cardiac arrest. That one makes it easy. 17% presented with shortness of breath as their only complaint. That is really important, really important. Weakness and dizziness, that kind of thing, was in about 4% as their only complaint. And which groups were these? Who were these people? Elderly. Elderly. People over the age of 70, it is more common to have shortness of breath as your only complaint with an MI, or fatigue as your only complaint with an MI, not chest pain. Your pain fibers change as you age, and your ability to kind of localize or feel pain really decreases over time, particularly visceral pain more than sort of cutaneous pain. This is important. They present with just shortness of breath or just fatigue. New fatigue in an older person, you really have to worry about a heart attack. It's just kind of a drag. It's just the way it is. And abstract number 13 is a slap the author paper. There are several of these. We'll talk about some more. This is when you're going to go up and slap this person. This slap the author paper basically it's one of these reviews of how likely is this person to have coronary artery disease papers. And they went through and took all the papers out there looking at presenting complaints, totaled them all up in this humongous table. If you pull this paper, it's remarkable. And then looked at likelihood ratios of different kinds of presentation complaints. They found certain things that were helpful. What they found is things like pressure-like pain increased the likelihood of it being coronary artery disease. Or radiation to one or, better yet, both shoulders increased the likelihood of it being coronary artery disease. What they also looked at was this person that goes, pica, 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 pica. I work at a Hispanic population. Pica, pica, acute, pica, pica. It hurts right here. Does that mean it's not cardiac? No. It makes it less likely to be coronary artery disease, but it is not zero. And the thing about this paper, they went through all kinds of chief complaints. And you can, is it positional, exertional, blah, 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 blah. The classic factors that we look for are helpful, but these sort of non-traditional, it's poking pain, it's when I move and twist, doesn't mean it's not coronary artery disease. This one doesn't help us, unfortunately. It's kind of a drag. Abstract 14 looks at basically 20,000 patients and says 8.5% are atypical presentation. So 1 in 12 cardiac patients are going to come in atypically. These are the ones, again, we're chasing. And the ones that tend to present atypically are women and older people. Diabetics a little, but not as much. Women and older people. Yeah?
Seems like what's hard to get a hold on is what the background figures for heart disease. If somebody came in with an ankle sprain and you worked them up for heart disease, would it be about the same number as people with these atypical kind of presentations?
Well, I think with heart disease, maybe. The question is everybody out there leaking troponin every once in a while? Because we seem to be finding, we all see these cases where I work in dysfunctional hospital numero uno in the country. And this medical screening exam thing we do now out at triage to keep people from waiting 4 hours just to get triaged. They send a gazillion labs at triage, and probably, I think we're probably up to 4 or 5 a week, we get a call from the lab, positive troponin. It's like, where's Mrs. Smith? Oh, she's still out in the waiting room from having been checked in 12 hours ago for some vague, and honest to goodness, our MSc docs, well, if you have a complaint from here to here, they send a BNP, D-dimer, and troponin, which I could just shoot them for, but they do. Makes me crazy. Makes me nuts. And we'll find somebody ruling in with really not anything that sounds remotely cardiac sitting out in triage about 5 times a week. I don't know what that means. I have no idea what that means. The data says that they do just as poorly as people who, unfortunately, the data says they do just as poorly as the people who come in with that whole crushing classic pain, which is kind of a drag. Now for the ladies in the room, guys, don't feel, for the ladies in the room, have you lately felt unusual fatigue? How about some sleep disturbance? A little shortness of breath? How about some indigestion? I'm sorry to break it to you, you're having a heart attack. At least according to paper 15. Paper 15 was in our lifelong learning papers we were supposed to all learn about and take a test on. This looked at women and how we present with cardiac disease. These are all women, aged 515 of them, from 29 to 97, who had a heart attack, a real, honest-to-goodness heart attack. And looked, they cheated. They said, okay, well, in the last week, how have you felt? And then the last month, how have you felt? Well, let's open this to the whole room. How many of you have been a little tired lately? Having any trouble sleeping? Especially with no darkness, that might have something to do with it. This paper is, I don't know what to do with this paper. It does, I already worry about atypical complaints in older people and in women anyway. All this does is make me more nervous. Is the fact that somebody's feeling anxious, anxiety. Anxiety's in here. Yeah, well, hey, so's the rest of the world. That's why Xanax is prescribed so liberally. I don't know what to do with that. And abstract number 16 says that women flat out present atypically more than men do, no question. Indigestion is actually one of the most common complaints. So a new indigestion in a woman, particularly if she's on hormone replacement therapy, worry. Okay, a postmenopausal woman on hormone replacement therapy with indigestion, be concerned that it actually may be cardiac. Now, abstract number 17 tells you the creativity of the publish or perish academic world. I work in that world. And this, I love this. Somebody, God bless them, published a paper on basically cardiac charades. Okay, the Levine sign, the palm sign, the shoulder sign, the arm sign, like this, or the pointing sign. They looked at how sensitive and specific those signs are for predicting true coronary artery disease. Gotta love this paper. They all kind of bite, just to be honest with you. They all are kind of terrible. The most sensitive one is the palm sign. This, not Levine sign, only 9% sensitive, sorry. But specifically, just so that you know, the most specific sign is the pointing sign. That is specific, not cardiac disease. So that's helpful. If you like that, that's charades. All right, let me get down to what I think is a truly helpful discussion, but I'm not going to give you an answer. I'll tell you what I do. You're going to have to decide your own risk-taking behavior. The last couple of abstracts in here, look at the concept. Let me give you a scenario. 45-year-old previously healthy guy comes into your emergency department who says the following. You know, yesterday when I was driving home from work, so this is now 16 hours ago. Yesterday when I was driving home from work, I don't know, I just got this kind of aching in my chest, and no, it didn't go anywhere. I didn't feel short of breath, and no, I wasn't sweaty, but it just kind of stayed there for, I don't know, an hour. And then it went away, and I didn't think anything of it, but I mentioned it to my wife this morning, and she said to stop by the ER on the way to work. What do you do with him? Get a 12 lead, it's normal. Totally normal. No risk factors. He's healthy. We'll close the doors. We won't let Jerry Hoffman hear anything you have to say in this room. What do you really do with him? I'll tell you what I do with him, but what do you do with him? Get a troponin. One or more than one? One. Why? I agree with you. Why? Greater than 12 hours, and actually probably greater than 6 is enough. Are you committing malpractice? Jerry Hoffman would tell you you are. Greg Henry would tell you you are. That a single marker, using a single marker, is a hazardous practice to do. I got to tell you, we all have to practice in real-world medicine. Okay, we all have to practice in the real world here. And to me, part of understanding markers is to understand what you get and what you don't get from a marker. What you get from a marker is damage. You have to give it time to elevate. Okay, so you have to give it time to leak and be measurable. Okay, that's a minimum of 6. So if he came in, if it was 5 p.m. driving home and he came in at 7, that's too soon. Okay, it may not have leaked yet for me to see it. But coming in that next morning, I've had plenty of time for that thing to be in his bloodstream. I'm totally fine. I have plenty of time with that. So what you get is damage. What you don't get is true ACS. So you're going to have 2 choices with this guy. What I would do in this guy is get a 12 lead. If it's normal, I get a set of markers, actually. We get MB, mass, and troponin. If those are both normal, I would set him up for a treadmill. Okay? Risk stratify him out. He's low risk. I'd set him up for a treadmill within the next 72 hours. Do I think he has new coronary artery disease? He could. Sure could. Sounded like it very well could be. You could, if you have a CPU or a cardiac unit that you guys treadmill right then and there. That's perfect. That's great. We don't have that. If you have that, that's perfect. You have to be careful how to use this test if you do it as a single test. The other situation where I use it, and this is a little dicier, is this situation. Well, you know, since Monday, I've just had this pressure. It's been there since Monday. It's now Friday. It hasn't changed. It doesn't wax. It doesn't wane. It's just been exactly the same for 4 solid days. Now, I asked those questions about 15 times to make sure I get the right story, that it's not, oh, no, it was gone for a while. No, it's back. If it was there solid, straight through for the last 4 days, that's the other time I'll consider using a single set of markers. Okay, that's the other time to use it. If I'm wrong, will I get sued? Probably. Can I defend myself on the stand? I think so. I think so. There is some literature to support this and some literature that does not. The paper that's in here that is concerning is Abstract 20. It looks at this idea of checking markers within the first 6 hours of presentation. And this paper does something I wish they didn't. They do it after onset of pain. Within the first 6 hours of onset of pain. Again, I want to know the offset of pain. That's where I want them to drop this flag to see and measure, and they just don't do it. But this one uses less than 6 hours coming in to see you or 6 to 24 hours coming in to see you. And the sensitivity of markers as a single set drawn in picking up true coronary artery disease, true bad outcome kind of stuff. And the sensitivity of a single troponin under 6 hours is about 21%. So we know it's terrible then. You know that's bad. Over 6 hours, it's only about 80%. If you add it with the CKMB, you'll bump it to 95% total. So that's why we send both markers where I work. We send both. CKMB picks up some of the later peak in this stuff, so you can actually, or earlier peak in this stuff. You can actually get that. Is this a bad practice? I think it's a reality practice. I mean, I think you have to deal in the real world. If you wanted to be an absolute no-risk taker person, you'd send one set of markers, another one in 2 hours, another one in 6 hours. If those are all negative, their EKGs don't change, you would either admit them if you're worried a lot, or you would treadmill them then and there, work them up on some sort of study then and there. Not all of us can do that. I mean, it just isn't. And again, what we're doing is chasing that 2 to 4%. This isn't the STEMI. This isn't the diaphoretic guy. This is I don't really think it's that. I don't think this is cardiac, or it may be cardiac, but I don't think it's bad kind of patient, and I think you just have to practice in reality. I can't give you a good answer on this. If you wanted to be low risk, you would keep them all and you'd work them all up, and I don't think we can do that. Questions on that? Because this causes a lot of debate, and if Jerry were in the back, he'd be doing his shaking his head thing that he always does when I talk about this. Yeah.
But it's not like admitting them is not exposing them to risk, too.
Absolutely. No question about it. You know, and it's depending where they get admitted, they may get unnecessary tests, and the tests themselves may not be appropriately positive. Excuse me. Yeah.
As a comment to compare this, only to make you more nervous, I have a book, and I think I've got 8 or 9 people already in the last 10 years who have come into the emergency department, my emergency department, having had a treadmill within the previous
Yes.
week that was absolutely stone cold normal, and they had massive MI.
Oh, yeah. Actually, I think Stuart's going to talk about that a little tomorrow. Yep.
Be able to rule this out. So what's the difference between taking one cardiac marker and sticking them on a treadmill? I mean, and that's just for me.
Right, and we'll talk, because part of this is, in the next half hour that I have, we'll talk about the use of previous stress testing results and what you decide to do. And Stuart's going to talk about how good the stress tests themselves actually are, because they're not that fabulous. And we all have had a case of this. We've all seen at least one. The one that I will never forget was the 45-year-old triathlete, who are now 50. He had just hit 50, called his cardiologist and said, I'm 50, I'm supposed to get my first treadmill, one of these kind of like OCD kind of guys. Got his treadmill, and was one of those guys that was going to run the treadmill to death. He's like, I am a triathlete, and they had to literally like pull him off the treadmill. It's like, dude, you're done. You're like, done. Get off. You're in a Bruce 95. You know, get off the thing. And it was totally stone cold normal. And he came in the next day with a STEMI, a Widowmaker STEMI. He had an anterior, huge, convinced it was the treadmill that had done it. You know, he was absolutely convinced that it induced his MI. But it's true. The testing that we have, short of cath, isn't that helpful. I mean, it's all right, but it's not great. Yeah. Pardon? Well, cath shows you what cath shows you is structural disease, not functional disease. And a clean cath is the most helpful cath result you can have. A non-clean cath, you kind of have to throw your arms up in the air. But a clean cath is helpful. Although you can, of course, still have heart attacks with those. So Prince metals, you know, the broken heart syndrome, you can still have heart attacks. Yeah?
Yeah, I don't know if you're going to talk about the delta evaluation.
That's the delta. That first thing we talked about, the Erlanger, the delta, that's the delta.
But ASAP, as you don't know, has a policy, the NSTEMI policy, that talks about a 90-minute rule-out using the triple marker. Care to comment on that?
I actually will have to look it up. If ASAP has a policy on that, I'm not familiar enough to comment about it. So I can go look it up, though, in the break and see. So, okay. All right, take a stretch. Sorry we're a little over, but we'll catch up.